Every colorectal surgeon gets complications, and when those go wrong, often colorectal patients can end up in intestinal failure. My particular interest is in intestinal failure surgery, and while that might seem esoteric to the average colorectal surgeon, the simple techniques in how to manage complications can prevent your patients ending up with intestinal fistulae and intestinal failure. I hope we'll explore that in Berlin more than we have here in Milan, and I look forward to seeing you there. Eve, thank you very much. Good afternoon, ladies and gentlemen. Thank you for asking me to come and give this talk on intestinal failure, which has been a subject that's occupied most of my waking hours and some of my supposedly sleeping hours for the last 20 years or so. It's a particular pleasure to be here the year that the ESCP produced these excellent guidelines. I wasn't involved with them, but they're excellent because they link very nicely the setup that you need if you wish to develop a service, but they also lay out very cogently the aspects of care that every colorectal surgeon could easily draw on when things don't go as they might, as you'll see. The ESCP guidelines also cross-refer very well to the other key documents that are out there that you can use if this is an area you wish to develop in your own practice. Manchester's had an intestinal failure unit for over 35 years, and Sir Miles Irving, who you see at the top of the image there, set up the first IFU. His great achievement, he said, was to be able to open it in what used to be the manager's car park. And in a long career of many glittering achievements, I think he saw that as his finest. Over the years, our stock in trade has come to be the open abdomen with multiple intestinal fistulae. I guess because that's often the hardest of the various challenges that IF brings. And our reputation for that has been such that every 15 years or so, we've had to upsize to a larger unit. And we're now in a third generation unit with 6 surgeons, of which I'm one, and 24 beds. We have a similar number of patients scattered around the hospital who don't quite need the full gamut of care that the IFU can offer. So let's start with a definition. This is perhaps the best one. It's quite simply the reduction of functioning gut mass below that which you need to digest and absorb food, fluid, or perhaps specific electrolytes, most notably magnesium. In other words, there's something about a shortened gut and poor gut function that together, that short length and poor function, means that you're not able to do what the gut needs to do. And we recognize 3 types of IF. Short and self-limiting, type 1, the abdominal catastrophe, which you as colorectal surgeons will probably all have caused and all have seen. I know I have. And type 3, the more stable, long-term, irreversible form of IF. So let's just think very briefly about type 1 IF, which is short and self-limiting. Patients recover with nutritional support. The challenges for us is to work out the ones which are not simply a rather prolonged ileus, but those who've got abdominal sepsis, and to be able to diagnose that and sort it. In the others, the challenge is to identify and feed and to avoid operating, because post-op ileus and small bowel obstruction, in the absence of sepsis, will almost always recover spontaneously. Of course, with an aging and comorbid population, you see group 2 there, the complex multifactorial group, more and more often. And they are difficult simply because of their multifactorial nature. You have to pick off the factors, you have to identify how to nourish them without upsetting their heart failure with TPN, and perhaps by using EN that will actually work, which isn't always easy. So a difficult balance, and you'll see throughout this talk, often the most difficult IF patients are those who don't quite sit in any one category. And that decision-making from this or that is one of the things that expert centers can sometimes help you with, even if you can manage all the other components yourself. So let's spend the rest of the time thinking about type 2 and type 3. Type 2, the abdominal catastrophe. Over 28 days, but still potentially reversible with all the complex metabolic, wound, septic, and nutritional problems that the open abdomen or intestinal fistulae or recurrent abdominal sepsis brings. They often need long-term specialist management, and identifying the point where you ship them from every hospital to a more specialized environment is a challenge. Surgeons are the most important etiological factor. You'll see that over 40% are only caused by surgical complication, but perhaps another 40% of these other diagnoses have a post-operative flavor to them. So something's gone wrong at a primary operation, and as you'll see, it's the failure to sort that going wrong that then turns the ordinary complication into intestinal failure. And I think this is a useful concept, that it's the surgery plus the complication plus the disease that together lands your patient in IF. You see the causes there, Crohn's obviously, but the big rise over the last 10 years has been that of permanent mesh inside the abdomen, which of course increases the rate of inadvertent enterotomy by a factor of about 40 and is extremely difficult to deal with and to deal with the sepsis once those problems have set up. Surgery that has an anastomotic leak that we'll think about in a moment, or enterotomy, obstruction with an abscess cavity, and the open abdomen are all sitting ducks to end up in intestinal failure. The anastomotic leak perhaps epitomizes how IF can be set up, and we all can either underreact or overreact. And you may look at your colleague next to you and wonder if he's an underreactor or an overreactor. Is he or she the ostrich? No leaks here, it's all fine. Denial is a great thing in colorectal surgery. I've been a strong advocate of it in the past with my own patients. The alternative is the superhero approach, which is where you're right in there, 3 new anastomoses on day 10, whip them off to ICU, reassure the family that everything will be fine, nothing else can possibly go wrong, and of course, if the anastomosis didn't work the first time, it's probably not going to work the second time with an albumin of 16 and 3 organs failed. And one of the things that we can best do to avoid intestinal failure is to avoid making anastomoses in adverse circumstances. And this failing to sort out the first complication is where IF comes from. You can either do too little or you can do too much, and either can land you in trouble. And that's why we have a policy in our hospital of involving a colleague when we have an anastomotic leak, so you get cold, calculated decision-making, and you don't undertreat or overtreat because of guilt or because of your knowledge of the patient and your wish to put them back to how you wanted them to be right away. You can get things wrong in Crohn's disease, the next most common cause too. And you see that IF usually results in Crohn's from complications. And complications happen when you operate at the wrong time and/or are unlucky. And that can happen either because the patient shies away from surgery and ends up with emergency surgery rather than planned, emergency having many-fold greater risk, or also because the MDT or the physicians don't refer the patient early enough. So surgical involvement in the IBD MDT is fundamental, so that when medical treatment has run its course, you want to operate as early as possible in as elective a setting and as well-nourished a patient as you can, because that's how you minimize the risk. So what about when things go wrong? Well, it's quite difficult, isn't it? But you've got to take a step back. You don't know when you're going to get the phone call, what the setting will be. Will it be still in hospital, gone home, in ICU, referred to you? But you've still got to try and develop a set pathway of going through this. And that's where the guidelines and the protocols help, because particularly if it's your patient, it's quite challenging. And the 2 key steps for the surgeons that you see on the slide are first and foremost to diagnose and treat sepsis, but also, unless absolutely necessary, to sit on your hands and prevent further harm by unnecessary or futile procedures out of a misguided desire to sort things out when now is not the time. And our algorithm in Salford that Nigel Scott formulated 20 years ago is the SNAP one. It's simple, so we can easily remember it. Sepsis first, because it's the greatest threat to life, then nutrition, then define the anatomy, and then an elective corrective procedure many months, often 6 months down the line. Sorting sepsis isn't a one-off, and that's the difficult thing about this. Sure, the first sepsis we're all focused on, but when it recurs, when it grumbles on, when there's line sepsis or fungemia or a blown rectal stump 2 weeks later, this illness just keeps coming at you. And that's where the resources of many departments get overwhelmed. It's not a fancy diagnosis, it's not fancy treatment, it's that it keeps coming at you, that you need an infrastructure that is able to cope with that when you're away or in the middle of the night. And so it's that recurrent theme that is the issue. For abdominal sepsis, we often use percutaneous drainage, first of all, if we can, for obvious reasons, but you've got to treat that with the same intensity that you would open surgical drainage, and in particular, make sure that the sepsis is sorted out. Early further surgery in type 2 IF is a thing we only do for unrelieved sepsis, and unrelieved sepsis that's going badly wrong. Because often this will be the third or fourth operation, often it will be 3 or 4 weeks into the mission, and the chance of collateral visceral damage is exceedingly high. So the indications you see at the top: organ failure, dead tissue, multiple collections not responding to drainage, those are good reasons for reopening the abdomen. There are borderline calls in individual cases, perhaps best discussed over a beer later. But when you go into that operation, you need very clear strategy. It's to deal with the sepsis and get the ends on the surface as best you can. You're not going to join anything up, you're not going to resect bowel, you're going to use the biggest drains you can find, and you're going to close the abdomen only if it's clean and not tense, which at a month in this process is not going to be very often, at least to begin with. So to put that strategy into pictures, green is the leak, red is your new stomas. If you can resect the leak and exteriorize, great. If you can close the abdomen, even better. If you can't, and typically with pelvic leaks, a proximal high enterostomy is a good bailout. That keeps the small bowel for another day and often controls the sepsis. If you can't get the leak to the surface, take the surface to the leak by opening the abdomen and leaving it wide open and letting it heal secondarily, a laparostomy. Putting into pictures, you see 2 of those options there. You see the proximal loop stoma and the open abdomen, T-shaped because it had complex fistulae, including the duodenum, so we made sure that all the enteric contents and pus would come out, and that's the sort of thing you're then going to have to deal with. And here you see that if you deal with sepsis and then get nutrition going, the open abdomen will heal on its own. These are the days before VAC, this picture, and you can see that it heals and shrinks very satisfactorily. But the reason I say stay involved is that this is the tip of the iceberg. And these sort of type 2 IF patients very typically will have problems with a range of things: wounds, metabolic, high output fistula, which you probably know more about than your ICU doctor. And you're going to have to conduct this orchestra of other specialists, the psychologist, the dietitian, the pharmacist, the radiologist, gastroenterologist, to bring them all into play in order to get your patient better. One of the specialist steps in this is fistula, wound, and stoma care. And this is one of the 2 things that our nurses do that let us operate at the point of our choosing. The other is nutrition, which I'll come to. And obviously, expert stoma care helps. Reducing GI secretions is important in helping you get early control. But the other thing that helps is to put suction in the bag or to drain the stoma bag into a secondary container, as indicated in the ESCP guidelines. We use a big jug on the floor because that stops the bag being heavy, it stops it leaking all the time, and you can imagine that repeated leaks of maybe 1,500 mils of duodenal content onto the skin is the last thing a patient wants when they're 6 weeks into this illness. What about nutrition? Is it all TPN? Well, no, it's not all TPN, but TPN is your fallback, and it's a great starting point. And you get more certain calorie input with it. You can avoid feeding a septic cavity. If you start the patient on oral or enteral nutrition too early, and there's still abdominal sepsis, you may feed that unless you've done a contrast study. It helps you with skin control. It'll reduce fistula output, which is the step towards getting a fistula to heal. So we would tend to rely on TPN for the first 6 weeks. If the fistulae don't heal, we then reappraise and move towards oral and enteral nutrition as well. And the backstop, though, is the feeding line. And for 30 years, we've had nurse-led policies that keep the doctors away, single lumen Hickmans, asepsis at all times. The patients are their own strongest advocates as they learn the techniques, and you see the remarkable rates of catheter sepsis. The only thing that I don't have to do with it is that I'm not allowed to be anywhere near it. This is a nursing thing, and the nurses are so good at it, they keep the line sterile, and that lets the patient get well faster so we can operate when the time comes. We're also great believers in distal feeding or enteroclysis, and we do that in two circumstances. We do it nutritionally when you've more than 75 centimeters. It's slow and it's complex. You can do it down a distal loop stoma or into a mature distal fistula. I wouldn't do it right away. You can get adequate amounts of nutrition in there to get patients off TPN or on much less TPN. But the other time we use it a lot is to be a trophic factor for the bowel in the run-up to reconstructive surgery. When you reconstruct the abdomen 6 or 9 months later, the distal bowel is often shriveled, and feeding it for several weeks beforehand brings it up to be more equally sized. And I certainly find that joining two ends the same size together is easier than a big one and a little one. So there's this prolonged recovery phase of about 6 months. And during that time, you might think nothing's happening, but the nutrition team are waiting for the patient to get nourished. I'm waiting for the abdomen to get operable. Because the thing that will determine the patient's future is whether the next operation works. The biggest predictor of mortality is another leak at your reconstructive operation. And waiting till the abdomen is soft and the patient's well nourished is the best chance you have of not ending up in that situation. The pitfalls in this 6-month period: the elderly do worse. Comorbidity is bad, obviously, and can be very complicating in many ways. If your first operation was for advanced cancer, you've then got to keep your eye on what's happening to the tumor, because quite a significant time period is going past. And there are intrinsic bowel diseases, some of the less common bowel diseases where you undoubtedly do want expert referral: Ehlers-Danlos, vasculitides, radiotherapy, etc. Small numbers, but when you get those, you probably want to get expert help in order to manage those. And throughout this, there's often low-grade sepsis, so repeated CT scans and septic screens are fundamental in trying to make sure that that's all sorted, because without it, the whole patient won't turn from being catabolic to being anabolic. During this time, we image everything, from the top, through the hole in the middle, from the bottom. And the reason for that is that we don't like surprises, apart from birthdays. And you see that there's a high rate of secondary fistulae and a significant rate of distal strictures, which of course will make your key anastomosis fail. Also complexity into the urinary tract, we see that in about 10% of our patients. So defining that and planning and ending up with a nice little roadmap, as you see at the bottom there, with lengths and sites of fistulae, helps you structure in your head what you've got to do and what your operative strategy is going to be when we come to the reconstructive phase. So when is that reconstructive phase? Well, it's when the patient is sepsis-free, well, and ready. You see those fistulae prolapsing, that means the abdomen's neoperitonealized, so you'll have a chance of dissecting it. The patient needs to be psychologically ready. We often get them home for a bit on TPN, and it's almost always more than 6 months. Chopping corners off there is likely to end in trouble. It's tempting to operate earlier. You can operate earlier if everything is set, but they have to be sepsis-free, they have to be anabolic, and you and they have to be ready to do it, and you have to have thought, is this the right place to be doing this operation? The patient has to be worked up anesthetically for what will be an all-day or more operation, and you need to have considered who else you need to involve: plastic surgeons, urologists, a colleague, etc. All that needs to be dealt with. And what about the strategy of the operation itself? This is sometimes under-talked about. Well, that's the thing you're going to sort out with the patient. It's going to depend where the holes in the bowel are and what you think you can really achieve. The first is obviously to deal with any residual sepsis. The second is to give them a manageable stoma. If you've had a fistula and an open abdomen, leaking all the time, having a good stoma will be 80–85% of the way to feeling well again. So having that as your number 2 aim is a good plan. You want to think about what's best in the long term for nutrition. And you'll see that both those two things lead into staged surgery. If you do a load of anastomoses and one gives way, they will all give way, and you'll be back where you are. Or not only will you be back where you are, but worse still, the patient will be back where they were, so you need to consider the price of failure for the patient. And abdominal wall reconstruction, is this the time to do it? We'll think about that as we go through. So, entry to the abdomen is an important part. We use the knife dissection the whole time. I don't think the small video is going to work there. I don't know if you can click on it for me. There we go. You see the very boring light strokes. IF surgery is very boring. There's nothing dramatic about it. It's painstaking and prolonged, and the whole aim is to avoid further enterotomies or damage. You dissect everything out, which takes ages. You measure the length of the bowel so that you know how much you've got and what the likely outcome will be, as you'll see if you make certain joins, and you preserve everything you can. Because in terms of quality of life on long-term parenteral nutrition, a small extra length can make a big difference, as we'll discuss. So how many anastomoses joined up is too many? Well, the answer is enough for one to leak, because it takes you back to square one. And I would do that based on functional gain. If there's a lot to be gained by one more anastomosis and all is going well, I will do it. If there's little to be gained or it's easy to defunction, I will do that and do a staged operation. Managing a proximal jejunostomy after they've been through an open abdomen with fistula is easy in comparison, and you can always feed them enterally through the distal route. Abdominal closure is the forgotten bit of, or has been the forgotten bit of this operation till the last year or two. It can easily take another 2 or 3 hours when you're tired. It's a good idea to get a colleague to come and do it. And there are big questions about how far you go with this in an open abdomen. Closing the abdomen is best, obviously. Sutures are best if you can do that. If you can't, how far you should go down the component separation route is an open point. We've done that for about 8 years, and if anything, I'm drifting away from it a little, because the worst situation is to do a big component separation, still not quite close the abdomen, and have had your best go at it, and not be able to put a permanent mesh in with that component separation, which clearly you can't do if you've got new multiple anastomoses. So often we fall back to the temporary mesh that you see there, close at either end, vicral mesh in the middle, retreat to fight another day, and close the abdomen at a later point. Of course, if you can do a component separation and close it, fantastic. So this rather laborious staged approach, you can see we do between 30 and 50 cases a year. The refistulation rate you see there between 2 and 6%. The death rate is tiny. We can get these patients out of this. And most of them come off TPN, which I think is a success. That still leaves quite a lot on TPN, and it's worth just thinking about that. In terms of patient expectation, remember that after surgery, they'll take a step back. So somebody with a decent length might still need TPN for a month or two, and you see the measurements where you can be reasonably confident that the patient will not require significant nutritional support. Better if you can keep the ileocecal valve, better if you can have all of the colon there, because that will give you leeway and fallback, as you can see. In terms of managing the patient with short bowel, it's complex. You need input from a specialist dietitian and pharmacist. And of course, we understand the high-dose PPIs, the diaurolite, to limit the sodium secretion, loperamide and codeine. But the other steps really fall within the province of the specialist gastroenterologist and dietitian. I'd recommend, if you're doing this, that you involve one. So let's just think finally about type 3 IF. This is the irreversible or almost irreversible permanent stage. And many of these patients are on HPN, home parenteral nutrition. And the quality of life, I could say, is fantastic in that. Look at where our HPN patients go on holiday. But, of course, that only paints part of the picture. It's a lot easier to go on holiday or to go away for the weekend if you're only on 3 nights a week TPN than if you're on 7 nights a week with extra IV fluids. And that's where the protecting every length of small bowel comes into making a big difference to the quality of life. So yes, it's life-saving expensive. Yes, quality of life is variable. Yes, a third of them work. You can get pregnant on TPN. But for some of them, they get complications of liver disease, line problems, and have a miserable time. And for that reason, thoughts continue to turn to whether there's anything you can do surgically to help type 3 IF. And we'll just think of intestinal lengthening and small bowel transplantation there. So there have been some papers published boldly describing closing stomas as surgery for intestinal failure and intestinal lengthening. I think that's just essentially the winding up of the type 2 operation. But over time, as you're on HPN, the small bowel dilates. And that gives an opportunity to use that in very selective patients to do what's called a step enteroplasty that you see at the bottom there, which effectively lengthens the small bowel. Here's a picture of my senior colleague, Gordon Carlson, with whom I work very closely. He leads our intestinal lengthening program. He does so for the country. And he's done a couple of these now where they've had a significant effect on TPN requirements. And you can see the process there using the stepwise linear stapler cutter to effectively give yourself a zigzag length of the dilated bowel. What I would say is that this is a very selected group. The number of patients who are suitable for this is actually quite small, or so far quite small. The alternative that's much talked about is small bowel transplantation. And in some ways that's seen as a rival to home parenteral nutrition. So let's just think a wee bit about that, about the why, when, and what are the outcomes. Well, its indications are for patients with IF who are failing on parenteral nutrition. And in other words, who have frequent, severe, or life-threatening complications. The top part of this slide shows you some of those complications. Liver failure, pending or actual. Thrombosis, in other words, you're running out of vascular access for your Hickman line. Frequent catheter sepsis, or if TPN plus IV fluids is not enough to maintain homeostasis in you. There are other indications too, certain multivisceral resections, and perhaps certain mesenteric vascular diseases, and perhaps quality of life. The operations are not all the same. Some involve a liver, some don't. Some involve other organs, some don't. And you see you can add in other organs at the bottom, the colon, the abdominal wall, which is tricky, or a kidney. And there are differences between the neonatal population and the adult population. So if you're looking at the results, make sure you look at the adult ones if that's your practice. And here you see the bottom line figures. These are the European figures to 2013. The UK figures are similar. And you see that there's a 5-year, 50%, perhaps up to 60% survival rate. Look at the parenteral nutrition survival, 90% at 10 years. So for those doing well on parenteral nutrition, I don't think there's very much doubt that you'd stick with that. But of course, here's the dilemma. Once you're doing badly on parenteral nutrition and are losing your access, you're then going to be a poor candidate for small bowel transplantation. What about the quality of life? Well, here are the things in favor of small bowel transplantation. You'll then be able to eat and drink. You may be able to stop PN. Your complications may reverse. But of course, you'll pick up all the issues of profound immunosuppression. A significant proportion of these patients end up in renal failure from renal toxicity, or have done in the past. And immunosuppression, of course, is lifelong with risk of tumors, etc. So we don't make these decisions between HPN and small bowel transplantation or intestinal lengthening on the hoof. We have a joint forum between the two major IF centres in the UK, St Mark's and Salford, and we involve the two major small bowel transplant centres in adults, Oxford and Cambridge, and the panel meets every couple of months to go through every patient who's being considered and work out jointly what the right way forward is for them. So in conclusion, Mr. Chairman, how do we minimise, as colorectal surgeons, the impact of IF on all our patients and not just in the small minority who end up in hyper-specialist practice? Well, judicious initial surgery and the obvious when there is choice of when not to do an anastomosis or when to defunction them. You've got to be realistic. And you've got to think if things are not going well, it may be better to defer that to another day. Things do go wrong, and when they do go wrong, you've got to be on them quickly, and you've got to make sure that first operation, the first take back, is adequate. It's timely and adequate. And if that means ends out on the surface, it means ends out. Once IF happens, you then have to have an algorithm that gets the patient through it to be able to have a reconstructive operation in elective circumstances many months later once they're well. And that's where the sorting the sepsis, nutrition, defining the anatomy, expert help is important. And that knowing when to retreat, get advice or involve other colleagues is also one that we can all take on board and which I do in my own practice too. I'm lucky I've got people on tap that I can turn to, but we've all got the phone and can always get help with complex cases. If you're going to do IF, as a surgeon, you're a tiny part, a tiny cog in a big machine. Here's just a handful of the other people that I work with and some of the other disciplines that are part of our service. Surgery is just one part of that, and if you're going to take these cases on, you're going to need the whole setup like that. And again, the ESCP guidelines lay that out. So, Mr. Chairman, thank you very much for the honour of being able to talk to ESCP. Thank you for the invitation. And thank you for letting me give this talk in memory of my friend Ken Fearon. He was interested in this field. He died unexpectedly a couple of years ago. He was one of the quiet men behind modern colorectal surgery, but the research he did probably impacts on things we do every week. Thank you very much. Happy to answer any questions. Guidelines are an essential part of intestinal failure practice because it's a complex practice which has many angles to it. There are some excellent guidelines which are available, most recent amongst which are the ESCP guidelines published in July 2016 in colorectal disease. I would recommend those strongly to you because they lay out not only how to structure an intestinal failure service, but a range of very practical mechanisms such as how to manage intestinal failure patients and also when to refer them to specialist practice. The most important part of management of intestinal failure type 2 is to identify and deal with sources of sepsis. While obviously this can be within the abdomen from a variety of sources, feeding lines, urinary catheters, endocarditis, fungal infections can all play a part. These causes are laid out in the guidelines which are available, but an important point to realize is that over the prolonged management of a typical patient with type 2 intestinal failure, multiple episodes of sepsis are likely to occur, and more than one source of sepsis may be involved in any one patient. Perhaps the most important step is to avoid creating new surgical anastomoses in septic or malnourished patients, because the incidence of anastomotic leakage is far higher than under controlled circumstances. Anastomotic leakage is one of the main predisposing factors to the development of intestinal failure in the longer term. For anastomotic leakage to progress to intestinal failure, it's likely there will be a further failed operation, and a failure to carry out a successful salvage operation is the second most important preventable factor.
And every surgeon can minimize the chance of that happening in their practice by early identification of septic complications, perhaps by involving a senior colleague in the further assessment of a patient with an anastomotic leak, and also getting them to help return the patient to theatre such that there's cold calculated decision making for that patient.